So, Rachel, are you there with me? All right, let's just get going. Thank you very much. And let's start with our PowerPoint. Let's start off with a bigger PowerPoint. It's 29, 30, and 32. It's 3 chapters out of the 4. I put the metabolic different in a separate one because there's some really intense information there. This is a PowerPoint. I have condensed it a little bit. There's stuff in the notes. So when you're doing it, go back and look at the whole thing. Trying to help you, I condensed it so it's not so overwhelming. 100-slide PowerPoints. I'm sorry. That's way too much to focus on, right? Sexual abuse in children is real, and I've seen it. I could tell you several cases that I've seen, from a 3-month-old infant to a 7-year-old boy who was starved of any food and strapped to a bed in a room and the door closed. And the kid came in and literally coded in our arms, and we took him to the trauma room. The end of that story, we were able to get an intraosseous IV in him, get fluid in him. We were able to save him. And I saw that little boy 1 month later. He was awake and alert. And just to let you know, with sexual abuse, your job is to make sure the children are safe. And if you think they're unsafe, you need to report it, okay? That is your job. Don't get angry at the abuser, because I could have been extremely angry, but it's better focus your attention on the child. Make sure the kid's taken care of. Now, sometimes older kids, they don't tell you, right? So you're going to see things like they're urinating, they're masturbating even, because now they know what that is. That they're stooling, they're nighttime terrors, bedwetting, and of course, any irritation or anything in the genital area. And
You
sometimes you'll
said
see them, yes,
you said stooling was stooling.
and caprices. And then that decrease, which means they're, these children will go in the corner, don't want to talk, they seem sad. You'll see changes in appetites, all different things. You'll, as a parent, something's wrong. And as a nurse, that's what we need to teach these parents. So how do we look at the urinary system, and how do we see if there's exams? Well, the first thing is a urinalysis, right? And then a urinalysis with a some sort of culture. When we see something that could be more, the urinary tract infections are due to something structural, we'll do ultrasounds, IV pilograms, IVP, looking kidney stones, CAT scans, biopsies. They get down to these uroflow cystoscopies to look inside, but many times on young children, frequent urinary tract infections, what the physician will do is what we call avoiding cystourethography. And literally, we'll put a catheter in these children, outpatient, sometimes a little sedation, depending, and they go in and we put dye through the Foley catheter into the bladder, and see if it goes up and down the ureters, and see if there's reflux structural going on. So that's what can happen there. We just look everywhere. We know there's dysuria, frequency, urgency, urinating at night, right? Enuresin, up at night urinating, urinating a lot or not at all. I mean, any of these things will describe something's going on with that bladder. Now, abnormalities. Phimosis is basically a foreskin that you can't pull back over the head of the penis. Basically, that's it. My little Christian, my grandson, at birth had a very long foreskin, and slowly we tried. And after a month, I couldn't get it down. So he had to go for circumcision because it will tighten up. And then it will literally put urine in there, and all of that schmegma and debris inside will get flowed and go back down the ureter and create urinary tract infections. So that was the reason why we do that. Now, hypospadias epispadias is a very interesting diagnosis. It means that the bladder and the ureter, the urethra, doesn't come to the tip of the penis. The epispadias, somewhere on the top it comes. There's no hole on the end at all. It just goes to somewhere there. And hypospadias is on the bottom. And what they do with this is they take the foreskin. They can't be circumcised. You have to take the foreskin and use it for plastic closure. And they literally, like this picture, they fillet the penis open, create a tube to go to the end of the penis, and use that foreskin tissue to cover it back up. Postoperatively, they'll put a tube in there to maintain the lumen of the hole. Okay, we do nothing with that tube. We just put it inside a bladder. It's almost like a little straight catheter that we would use on babies or infants, or it actually it's the same size that we use for adults. That little plastic, we'll put it in there and keep it in the bladder, and then they usually take it out 7 to 10 days later. We want this done usually before potty training, which is about 18 months. Okay. Some kids are earlier, but usually that's about the thing right there. So it's another picture where it could be, remember, anywhere on the top or the bottom. Something else that can happen is what we call exstrophy of the bladder. The bladder is born on the outside of the body. So can you imagine this tissue, because the abdomen didn't close, it kept open and this bladder came out. You need to protect that skin and protect it from infection. You can see how there's some redness going on already around this tubes. And what they do is that bladder's still connected to the ureters and to the urethra, still all the same structure, but it's on the outside. So you put a diaper on and catch the urine, just like you would on a normal newborn. But the bladder's out, and our job and our priority is to protect the skin, put a lubricant down to protect any oozing and to keep that tissue free from infection. These children will be on their back. They will not be placed supine. So of course they'll be on a monitor. Obstructive uropathy. Remember I said there could be things like, well, you have a kidney stone, a calculi, or tumors, strictures. Sometimes you'll see a flow can't go up because there's a kink in the hose, basically in the ureters, and the bladder can't drain. So that creates hydronephrosis, polycystic kidneys. So many times with these, they try to fix it. And they do sometimes diversion surgeries. Now, sometimes if they're really restricted and we can't do connection, there's all different things that we do to have them trying to look like they urinate the way that they should, that they'll try to connect it down into the bladder. But it's a lot of surgery for that. Now, urinary tract infections in girls, really common. And they love bubble baths, right? So they sit in this dirty water, and that dirty water can get up into their bladder through their urethra. Remember, it's short, it's open, it's right there. So that's what happens. So what is our goal with girls? Well, as they're potty training, wipe front to back. Boys don't have that much of a problem because they have a penis to protect it, right? But that girl is right there. So you got to wipe front to back. Also, those cute little tight pants that they love to wear today, and they're adorable, but they hold heat and they're nylon, and it creates heat and moisture, which again can cause infection, and it goes right up into the urethra. So they should just wear cotton underwear. And of course, increase fluids. It's number one to prevent them with, not doing bubble baths and again, wiping the right way. So understanding that signs and symptoms is that, the frequency, the urgency, and maybe even, redness down there. Infants with urinary tract infections, because they don't have an immune system, are usually placed in a hospital for IV. Older kids can get the oral stuff. Just making sure that they finish the entire dose of it, okay? And again, making sure that they keep front to back and teach them all those things for prevention. So, and the interventions is cleanse it, wipe it front to back, no bubble baths. And then they say if they go into a bath, maybe you treat them, special day, right? Girls love that. Lots of bubbles. Make sure that they urinate after the bath. And most kids want to urinate once they hit the warm water, right? So explaining that, try to do it. Those underwear, loose fitting pants, and of course, more fluids. Now, nephrotic syndrome is probably the most confused of all the diagnoses. Has nothing to do with renal failure. The kidneys are working. Again, this is not renal failure. All this is that the kidneys say, proteins, you're disgusting, yuck, I'm urinating you out. So what happens? You lose the protein in your body, okay? You don't have protein, it comes out of the blood system, fluid goes into extracellularly, and these kids are puffy, swollen, edematous. So we do put them on steroids, and that helps them. And because of all that swelling, your job, intake, output, and a good daily weight. As I said, you'll see that edema, and it's mostly around the eyes, right? You can see it in both of these things. And again, be careful for infection, especially with neutropenia. Remember what neutropenia is. Neutropenia is a low white count. Neutrophils is neutropenia. That means low white counts. What happens when you have a low white count? You're prone to infection. And these children are during these stages. This is something you don't cure. This is a lifelong thing. Treatment, as I said, it's steroids. And you need to be very careful with giving medicines because there's no protein. There's no albumin in the blood. Albumin is protein. And medicines go into the body, into the blood system, and they hop on this protein or this albumin. And then the rest is all free drug. Well, there's going to be too much free drug, which is your drug level, because there's nowhere for it to hop onto. Okay? So doses are a lot less than what you would normally put them on. Diuretics don't work. They don't work on it. So you're going to watch the salt, you're going to watch the fluids, you're going to watch intake, you're going to watch their output, you're monitor daily weights, and the steroids is going to help them there. Again, it's all supportive and for them to understand. Now, this is that child that's going to have those vaccines held at some times if they're in the acute stage of it. Remember, as I said, they are prone to infections. They are immunosuppressed. So that's one thing that they need to be aware of and to tell their physician before they want to get them. They're told, the parents, watch their weights. They see a weight gain, they know something's going to come on. Now, glomerulonephritis. This is due to strep. That's that strep infection that mommy didn't give the whole dose to, and because the throat was better and okay, it's fine. Well, glomerulonephritis is when there's an allergic reaction in the kidneys to this strep. And sometimes it's other things too, but let's just say strep. And both the kidneys are affected, and these children will have, with this glomerulonephritis, you'll see puffy, puffy, puffy also. They're oliguric, they're not urinating. And these children's blood pressure are high, and we can cure it. How? Treat the strep, and then symptomatically treat the other symptoms. Now, Wilms tumor is a nephroblastoma, which is a kidney tumor. And what happens is, I usually will see this in your younger children, 3 to 5 boys, a lot of them. And they don't see or feel anything, but all of a sudden there's this big mass in the lower abdomen. I've seen one of these cases in my lifetime, and it's an African American trait that more towards there. And this child came up to us through that that earthquake in Haiti many, many years ago, maybe 10 years ago now, I don't know, quite a while. And they sent this little boy up with a religious group, and they had records, which were only in French. And I'm the triage nurse, and these people went to the airport, picked him up, and brought him to me. And I said, so why is he here? And they go, I don't know. So I couldn't read French. So I had to do an assessment, and I got on that child's level, made them comfortable. We don't speak the same language, but kids don't need to. They can sense you. Got along with him. I was listening to all vitals, etc. And then I felt his abdomen. And in the left lower quadrant was a softball sized mass. And for some reason, I knew it was a Wilms tumor. They can be treated, and they usually, with these patients, this tumor is very fragile. So touching it or trying to biopsy it, you've just introduced that cancer to metastasize into your peritoneum, in your belly. Okay. So we don't touch the abdomen. That is the big nursing thing on this. And we don't do anything to it until after they do surgery. They do surgery, radiation, chemo first, and get it done and get it out. Okay. Usually these kids do okay. All right. So big thing is don't palpate that abdomen. Hydrocele is just extra water in the scrotal sac, and I'm telling you, it hurts. And if it's a persistent, they can do surgery on it. Cryptorchidism. Testes don't go into the scrotal sac. Why do you think the pediatrician, first thing on the first exam with a little boy baby, is they look at the testicles? They want to see if they are in there, right? Because they want to make sure there's no cryptorchidism. They don't like to be in the belly. They get too hot and they die. And we want to make sure that we don't make this little boy sterile, because it will happen if we don't treat it. Sometimes these, when you have these cryptorchidisms, you are in the future more subject to tumors. Okay, so just to let you know. What do we do? Well, if they're older, scrotal support. After surgery in a baby, most of them that are done, they diaper up really good. And then as this kid gets older, they need to be taught to check their testicles. Are they there? Just like we do breast exams, boys should be doing that monthly. Now, sometimes doing surgery on an older child who understands creates problems and mentally, right? They're curious. They know, remember, preschoolers starting to understand boys and girls, right? And they know that there's differences, and they're curious, and they're even touching themselves down there. So make sure that we talk to these children about surgery, what is going on, how to touch or not to touch themselves, because these kids will. And we don't think they do, but I'm telling you, they do. So skin conditions. So what do you think these things are here? Some really good ones, right? So let's go forward and I'll teach you. So the skin, we've got these, there's a difference between adults and adults and children. And we know that has to do with the water in their body and the surface size and all of those things. So children are more susceptible, bottom line, okay? We know that we look at color. We look at, is it soft? Is it pliable? It's, the quality. All of those things are things that we're doing in that little looking at that kid. If we don't see hair and there's patches missing, it would make us think about what do we need to do. Now, when you're looking at skin disorders, you describe what's the color of this condition. I mean, look at these children here. They've got these scalded milk things and they've got rashes going on. Your job as a nurse is to say the size of it, the color it, is it configured? Is it like just a big mass, or is it little tiny peticuli, papules, macules? What are they? Okay. And what is the condition of the skin that's not on these rashes like that little baby boy? Now, managing a lot of these disorders is applying a cream of some sort or ointment. Now, we need to, number one, know that children in skin conditions love to touch it, right? They scratch it, keep their nails short, right? They can't get underneath it and break it open. And if you're applying any creams or lotion, remember, these kids absorb this through their skin. So don't overdo it. More does not make an ointment or a cream any better. Only apply a little bit. A little is better. So these are your different names here, okay? Macule is just this flat rash. Vesicle is when it's up, that's chicken pox. You'll see it up with juice on the end. Scabs, we know what that is. We've all had them. There'll be some papules elevated, but nothing on the top. Pustule is elevated and it's full of pus and gooey. That's either a pimple, acne, or it's something called impetigo staph. That's what that is. And then a wheat is just a raised red, like mosquito bite, like there's an irritation. And we know ecchymosis is a bruise. So a sty, that's like a pimple in the eye, right? Into the eyelid, anywhere there. We see this a lot. Strubby nevus, this is a hemangioma. Many times they go away with creams and ointments. We usually don't do surgery. It's usually some sort of creams and lotions that they put on there. And we don't necessarily see it when they're born. It could be later. Port wine navis. I've seen them on the face, on the arms. They're all over the different place. And again, this will not disappear. Okay, this is something that as the kid gets older, it's going to be darkened some more. I'd like to get the pictures for you, so I went searching for these. Cafe au lait. It looks like a coffee spill, doesn't it? That little and cream there. The hypopigmented, that's like that black white. That was Michael Jackson, right? Didn't he have black and white? And he tried to cover, the difference of colors. He didn't, surround it and hug it, embrace it. He covered it. These are some of those skin things. Butterfly rash. You've heard that with lupus, haven't you? And that's one of the ones that it could look like, or it could just be a pinkish. Doesn't have to be as bright and red and flaming looking. They're all slightly different. Scalding skin around the mouth, around the mouth. And this actually, they say, could be due to zinc deficiency. So sometimes they're nutritional. A vascular birthmark. It's a bruise that changes appearance. And sometimes hemangiomas can be there. But again, this is a blood filled with vessel type of rash. And it can be with different treatments, make it not as pronounced. Milia. This is that prickly heat. We see it all over the place on babies, right? We can see it on their perineal area, their buttocks, underneath their necks, and it's something that what we need to do is just keep it clean and keep it dry. That's it. Chafing. This is sometimes, could be due to, urine, stool, heat, moisture. That's underneath the neck, right? You feed the baby, it drools, goes underneath, and some of these big chuggy necks, right? And it's really hard to get underneath. So making sure we clean it well, that will help that also. Seborrhea dermatitis. Now, dermatitis can be something that it's sometimes is lifelong. Sometimes it could be the beginning. Cradle cap. Babies are born with this big, conglomerations of stuff on the skin, and it doesn't itch or anything. It doesn't look good. The treatment is just shampoo them and soft brush. Sometimes they even say with cradle cap to put a little bit of oil on there, keep it moisturized. Diaper rash, we've all seen them, right? Baby does not like diaper rash. Diaper rash can be due to many things. It could be due to response, could be due to medicine. My kids were allergic to pamper diapers. Put one on, and in 8 hours, that's what their butt used to look like. So guess what? They had no more Pampers. And my grandson was the same way. So sometimes you just got to figure out, well, I'm on the best shampoos, the most hyperallergenic and lotions and creams and, laundry detergent, and this happens. It could be food, or it could be like the diaper or even clothes type of materials. Acne, all different things, right? You could see them really severe, closed. There, it could be blackheads or just open type the whiteheads. How do we take care of acne? Well, you can apply to one of those very expensive commercials, right? Or they just say routine, good cleaning and making sure stress. That can also part of it. And then those little areas, maybe that they're open and they're infected, maybe a little, the antibiotic cream or something. But there usually will be this really long type of list of things to do, especially those resistant. We used to put toothpaste, white toothpaste, on them to get rid of them overnight. Well, this is many years ago when I was a teenager. Herpes simplex. Look at that little baby boy, little baby girl. This is all herpes there. Herpes is a cold sore. I mean, we've gone out in the sun or got a fever and we've got one on our lip, right? Well, this is a really severe case of it. And it is a virus, right? So this severe, we would be given an antiviral oral, and we'd be put in viral medicine like acyclovir, right? That's one of them we might do. Eczema, infantile eczema. And this is basically, we just keep these kids clean and moistured. And then there's very benign sort of medicines that they will put them on. And we can see that these children do improve, but it does take time for this one to clear. We usually see again rashes and stuff. They become really bad when we start feeding them other foods. Again, food allergies. Sometimes they're bacterial, sometimes there's viral. Depending on that will depend on which type of medicine do we use. Do we just do cream, lotion, or do we need an antibiotic, something? And they're saying with immunizations, your immune system is being boosted. Sometimes you'll see them boost up. So eczema is itchy. So again, keep those nails short on this baby. Again, emollient everything. Keep this kid as moist and greasy as possible, right? You can see it, that's the biggest part of it. And if that's not working, of course, they can give you things. But corticosteroids has their own side effects, even topically. It's that steroid, it's Cushing syndrome, can happen just from topical, especially on a kid who has eczema, because it takes a while to get rid of it. Antibiotics, if they're oozy and juicy and infected, and anti-itch medicine can be given for that. What they're saying is to wash off before you re-put on. And really good hints here. Best absorbed after a warm bath, right? And then put it with the level where the hair grows, not against it. It'll go in always, proper amount. And if a kid is really itching, going bonkers, you can put these elbow restraints on, especially if it's, somewhere where they can't reach with their elbows not bent, okay? If it's on their chest or if it's on their head, elbow restraints will hold their arms straight. They can't get to there, right? Staph infections, we see these a lot on children, which could happen in their belly button. And why do they get these? Well, remember, kids have no immune system at birth. And that newborn could have been touched by someone who didn't wash their hands. It happens. And, went to the umbilicus and created an infection. So remember to try to treat it topically. Topically, we can't get it. You're going to have to do IV antibiotics on these children. And then the worst of all staph infections is your MRSA, right? Methyl-resistant Staph aureus. And these will be placed on contact isolation. It basically just tells you got to be really careful with these children because you can spread it. Scalded skin. Look at the way the skin just peels off. I mean, it looks like they're red, right? And then their skin peels off, and then they heal it. But it generally heals without scarring on these children. Impetigo. My little grandson had it on the back of his knee, and his mother said he just in his sleep scratched too much. And I looked at it, I said, no, that's impetigo. But, I'm like, all right, let me see what mom says. So I just put on a good antibiotic ointment on the back of it. Well, the next day it was worse and worse and worse. And now he's in pain. It's ooey and juicy. So after a week of, and I had muprosine, Bactroban. I had the good antibiotic ointment. We had to call the physician and we had to get oral antibiotics with it. So it is staph and it is infectious. And I had, as a person, had to be very careful of hand washing because, I'm immunosuppressed. I have rheumatoid arthritis. I can't afford to get it. So but the kid stayed with me and I treated it for a week. We got him good and we got him back to school. Fungal infections. You think of fungus, do you always think of things like alopecia, hair loss? It is like these little round circles, you've heard of roundworm, little circles and stuff, all over the place type things. You can see little white spots. All of those things are a fungus and need to be treated with an antifungal cream. Ever have lice? Lice can be horrible. My daughter had it, and my son when they started kindergarten and first grade. And my daughter had hair down to her butt, and her hair was like triple thick than most people. So I had to literally shampoo it and comb it and comb it and then wash everything in the house. And then she came back with it again. So I had to do it all over again, but I still left her hair long. Remember, we have to leave that cream on for it to work and then shampoo them out, very dependent upon that. It could be pubic, we could have the crabs, body lice, head lice, any of it. And the goal is to get that in the eggs. And usually you treat it once and a week later again, depending on the physician. Scabies. Scabies is another little parasitic little bug thing that gets in you. I see this a lot with after staying at a hotel, and the mattresses have them. Usually, people don't normally get it. It's usually traveling is where I see it, and they take and put eggs in your skin, and they keep hatching and hatching. And what happens? It will go from child to parent to anybody else. So everybody needs to be treated for this. And you treat it with that permethrin. It's that lotion that you put on, and it needs to stay on there 4 hours, and then it can be washed off. Burns. Kids are always grabbing things, right, off the stove. I have an older brother who burned his whole arm by putting his hand up on the pot and getting it. And there were 7 kids, so if only one kid got burnt, it could have been a lot worse. But remember, sometimes this could be abuse or neglect. And I'm going to give you that example. I was working in an adult ER at the time, and they brought a baby in, and they had burns on their peritoneal area and their butt, and up a little bit of their legs and a little bit of their back. So it looks like they sat in something hot. You know what happened? They had the bath water scalding hot and put the baby in it, and they burnt that baby on the perineal, the rectal, and the buttocks and the legs. That was an injury burn. Was it neglect? Something that had to be investigated, right? There's thermochemical, electric radiation, all different types. Just know that what you see with each of them, they're all a little bit different. Body surface areas and how much burns, that is all of your rules there. Adults and children are different. Remember with burns, remember if they have any burns anywhere in the upper extremities area of the face, always worry about the airway. You don't know if they inhaled it. So, and remember, it doesn't have to happen right away. It could be a little bit before that swelling occludes the airway. So number one priority is always airway, especially like a kid like this. That one, of course, first thing I'm going to secure an airway, right? Because we want to keep them breathing. Plus, you can medicate them really well to do all the burn treatment, right? Again, there's all your burn sizes. So we know with kids and burns, the skin is thinner. We know that it goes down deeper, quicker. We know if there's a lot of fluid in there. And we know that this child needs fluid resuscitation along with taking care of that pain and all the dressings. And then nutrition, nutrition, nutrition. They need protein and they need extra calories. The body needs to build new skin. Children, how do they respond? They actually do pretty good. As long as you give the good nutrition, you do all the treatment the way you should, they do well, but you can see they probably are going to have a bigger scar because they go down deeper more than the adults. So the scars can be bigger, but they can recuperate. Sunburn. I live in South Florida, right? There's always sunburn going on down here. And what is our goal? Well, we tend to, as Floridians, go out to the beach, to the pool, forget sunscreen, get burnt, right? And then suffer later on. Well, through years of doing that, we've learned that if we spray ourselves with a good UV something, we could protect that. What I do now, I won't go outside till 4 or 5 o'clock in the afternoon, and I won't stay out forever. And I have found that I have not been burnt in many years because of that. And I always have a little bit of a color to me. So, and always in the sun, hydrate, hydrate, hydrate. Frostbite. I mean, I used to live in New York and I used to go snowmobiling in 18 below weather. So I'm very aware of frostbite and things that can happen. And frostbite basically is lack of circulation to extremities, usually fingers, toes. And it can cause fingers and toes to be lost. Okay. Now let's get into some communicable diseases. Terms. These are terms you need to know, okay? Communicable means I can give it to you, you can give it to me. Incubation. There's always a time, and we think of chickenpox, right? Where you're exposed until when the rash appears or exposed until the illness appears. That's incubational. The prodromal, especially talked about with chickenpox, is the time between the earliest symptoms and then when the rash comes or the fever. And that vector is that insect who gave us. I mean, just think about getting ticks and getting different malarias and all different things. Pandemic, that was worldwide. That was COVID, right? Epidemic is maybe there's a bunch of GI, vomiting and diarrhea in, one certain area. That's an epidemic. Endemic, it's a continuous, constant. It keeps going. You don't cure it. So it's a epidemic that keeps going. Opportunistic infection is something that's caused by that environment. So think about HIV and PCP pneumonia. PCP pneumonia is an opportunistic infection. And healthcare associated with infection is an infection acquired when you go to a hospital. MRSA, that's the big one, right? We know that there's ventilator type of infections, urinary type of infections that are transmitted in the hospital. And I want to know that today there's less than there ever was because there's been a lot of research, been a lot of programs made, and a lot of what the Joint Commission telling us you need to watch. There's too many of this in your hospital, and you have to develop a program to stop it or decrease the incident, and then you have to research it. So the virulence of the infection depends on the age and the sex, the genetic makeup, nutritional status, physical, emotional health, and then it depends on your immune system. So if I got something exposed, I'm immunosuppressed, so I'm going to get it pretty bad. A normal person who's healthy with none of these immunosuppressive diseases are going to be able to fight it easier because you have a functioning immune system. Okay. That's what that means. Now, important thing, types of immunity. Well, natural, you have it. It's just there. Maybe it was, you know, mom gave it to you or something, but you had it. You've always had it. Now, acquired is why we do immunizations. You're not born with it, but it's because you've gotten the vaccines or you have a disease. Okay? Acquired. It's something that you've gotten either from the disease or from a vaccine. Active immunity, your body just does it. We do it all the time to viruses. We do active immunity so our body gets their immune system better so we don't get it again. And passive immunity, it provides that antibody to that person. It really doesn't last all that long. So preventing infection. Well, what do we do? Well, it's always technique, right? It's what sort of PPEs are you going to use? You know, we do need to do universal precautions with everyone. Washing hands is number one. And then, of course, using the proper equipment for different things. You know, airborne TB is a big one of them. And varicella, chickenpox is airborne. Making sure if we have that N95, remember there was a big shortage of N95 masks during COVID because that's what you needed to keep the airborne away from you. So N95s are used for those severe things. Contact is anything that can get on your skin and it can contact you and create an issue. Again, wearing gloves when you're going to be exposed to blood, urine, stool, mucus, whatever. Droplet. You use a regular mask. It's not like an RSV. It's for you and me is a virus. It's 6 months and under that they really are sick. So the RSV is not us, but we're going to put a cover gown on and gloves so we don't prevent the movement to another child, and a regular mask. Hand hygiene, well, we know we count what happy birthday 2 times and then we wash our hands. Today, they are very strict about nail polish and nails. I mean, they used to always, when the artificial nails became the big rage, everybody was wearing them and they stopped it. Now they're like the gels, but still it lasts there a long time. So they have found that there's staph underneath the nails, basically. So they shouldn't be worn. But as nurses, we want to be pretty too, right? So we do wear them. So infection, spreading, you know, what do we educate our family with? Well, always hand washing. Number two, promote immunizations. Proper food storage, making sure that they know food should be put back into the refrigerator, washing surfaces when they have like chicken or anything on there before they cut up the salad. Pasteurized milk. I used to drink the milk right out of the cow when I was a young kid. It was really good, but it wasn't pasteurized. Thank goodness we didn't get anything. Towels. That's why we have blow things in all the places, or we have paper towels. Insects, ticks are a big thing, right? Causing all sorts of diseases. And then sandboxes. And why sandboxes? There's all sorts of worms and stuff in there, right? And they can cause problems. My kids love sandboxes, but they really aren't good. Okay, I've sort of talked about some of these rashes on the skin already. So pathognomic is the term that it is the type of lesion that's too specific to your disease. That's the only different one here. And they give a great example. Koplik spots are seen in measles. They're not seen in other rashes. So those again are the rashes. You know, healthy people, one of their promotion is to immunize our children for communicable diseases. You know, they're providing I mean, look at how many COVID shots were given out free, right? COVID tests handed out free. A lot of this has to do with the promotion of the World Health Organization, healthy people, all of those things to help us keep us healthy, especially our children. Vaccine, we know it's usually not just one vaccine, it's multi doses. Look at the first couple 2, 4, 6 months, 15 months, 12 months. I mean, that's 4 in a year, but it's what it needs. Again, making sure that we give vaccine properly, handle them properly, and if we're giving it, that we don't try to reuse things. Okay, again, giving it properly. Now, you can get an allergic reaction to a vaccine. Always think about anaphylaxis, and remember, epi in any doctor's office, urgent care, ER, wherever they're giving vaccines, they do have that. One of the things that we need to teach our mothers, fathers, and children is when to avoid a certain vaccine. Baker's yeast, hepatitis B vaccine. Eggs, it's the influenza vaccine and MMR. And neomycin. There are things that if we're allergic, we can't take a vaccine. And that would be different, okay? Contraindication. Well, immunocompromised states. You do not give any live vaccines to that person. Pregnancy, some of them are given, but a lot of them they'll withhold. If you're sick already, bacteremia, meningitis, right? Now, if you have somebody at home and you're getting a live vaccine, what sometimes they say is you need that doctor to say it's okay for that other person to get it if you're at home, immunosuppressed, okay? Steroids. Remember, if you're on steroids, you are immunosuppressed. And if you're sick, they're not going to give it. Bioterrorism, who knows what, is going on with that. We always hear these things. Just remember keeping our bodies healthy, keeping ourselves and our immune system as well as they could. And that is all we can do. Emergency preparedness. I live in Hurricane Central, right? So having a hurricane hit kit is always important. So always make sure there's food, water, pet food, baby diapers, right? Warm clothing, blankets, medicines, and then any copies of anything that you need to keep. They say to have a battery powered radio, and of course, a little first aid kit always helps. So this is something that you need to be prepared before it happens. Remember, babies and children, pediatric patients, they are all more susceptible to all the things that can happen during a disaster. So just remember that they could have, childhood asthma. They're inhaling it. It's going to create, a status asthmaticus situation. Also know that they're going to absorb some of this stuff, disaster and dirt and whatever, like for instance, hurricanes stir up, right? Just to know that we need to be prepared. Sexually transmitted infections, we know this is sexual activity. It can go from mom to the baby. It could be, given if the sexual abuse of any type. Of course, if there's drug use and contaminated needles. And these are things that really need to be taught about, especially to our adolescent group. So number one, you're going to talk to these patients about all of these very sensitive things, make them feel like they're safe and that you're listening and you're not judgmental. I mean, you get that 16-year-old kid who, did something, whatever, and now has gonorrhea, and you have to talk to them about it. Make them feel like, okay, things happen. It's okay. Do you know how to treat it? These kids are embarrassed. For getting a teenager to admit that they have a sexual transmitted disease is huge because they don't want you to tell anybody. They don't want you to tell mom and dad. They're not supposed to be having sex. Think about that. So try to get on their level. HIV, AIDS, we know most of those things that we see is that they're not gaining weight, just like an adult would be, the swollen lymph nodes, etc. But the things is those opportunistic type of diseases, right? Thrush, PCP pneumonia, herpes, and CMV virus. Again, these are things to look out for so that we can treat them. We treat them with antivirals. And we know there is no cure, but immunizations can prevent them being sick with something else. A lot of information, huh? Can I take a breath now? The next one is the metabolic system. And the metabolic system, as I said, I put it in a different PowerPoint. It's 36, 30, 38 slides. I try to condense it a little bit for you. Try to give you what you need. So children metabolic condition, I mean, the first thing I always think of is diabetes, right? And children do give their own injections and monitor their own blood sugars. They should be encouraged to. So endocrine system is pituitary gland, thyroid, parathyroid, pancreas, the adrenal glands, and of course your sex, whatever it is. What do you see in the endocrine system generally, any of those diagnoses? Well, you're going to see them, especially younger kids. They can't tell you how they feel, but all of a sudden they're not eating well. They're tired, fall asleep easy, and now they're not gaining weight. They're vomiting. You might even see that liver below that right rib cage. You might see it getting big, okay? Sometimes because of this lethargy, poor feeding, then you see things like delay. They're not doing those milestones that you look for. They're not turning over completely by 6 months. They're not sitting up by 8 months or even attempting a step at 12 months. These are things that we are going to look at why. What is going on? That's why early intervention is also figuring out why this is going on. So we do all different things, all different tests, these things, and so many more. Tay-Sachs disease has something to do with the Ashkenazi Jewish population, and it has to do with fat that gets on the nerves and it doesn't allow impulses. And what happens is there's cognitive delays. The physical, you're not moving right, and then you're not thinking right. There is no treatment about it, but usually, look at this. It's not seen to 5 or 6 months. So that's why we do those developmental days, right? That's why we're seeing something's not right. They're not where they should. And if we do continue, parents don't, or we don't see what's going on, it will go to blindness and mental retardation on it, okay? There's really no treatment, but at least we can understand and offer some sort of, therapies for this. Hypothyroidism, not enough thyroid hormone in the body. If it is congenital, it's one of the things that we'll see no stool on these children, and then we'll test for it. And we know that they need their thyroid hormone for good cognition and growth. So very important. And this is the most common type of congenital or any endocrine disorder in children, hypothyroidism. So because of that, there's mandatory tests now. This kid is asleep. This is a kid who's lethargic. You're going to see noisy respirations. Their skin is dry. They're going to have their hair is sparse, intolerance to cold or to heat. They're constipated. They're not going to be cognitively where they should be developmentally. All of these things are hypothyroidism. It's all about what it is for adults, but add in also they need it for growth, cognition. Those are two things that you add on for the adults. There is something that we call Hashimoto. It's a lymphocytic thyroiditis. It is a hypothyroidism, and it is an immune disorder. And all we do for this one, you can't take it out, you have to leave that thyroid there, is you need to give replacements of the thyroid hormone. So they're monitored closely. So they give them, we get the hormone levels, and then if because we didn't catch it, they're delayed, we try to catch them up. And this will be lifelong treatment. That's not something they grow out of. Now, one of the things about giving thyroid replacements, remember there's hypo and hyperthyroidism. Hyperthyroidism is too much and hypo is too little, right? So when we look at giving too much thyroid replacement, it's going to look like hyperthyroidism, which is a rapid pulse, dyspnea, irritability, weight loss, sweating. And then too little is again like hypothyroidism, fatigue, sleepy, constipation. So do you see how one mimics the other? So teaching them about hypothyroidism, you're also teaching about hyper, and hyper. Diabetes insipidus. This is the pituitary gland. It regulates fluid, has not a thing to do with blood sugars. And why they call it diabetes insipidus, I don't know. But what it does, it regulates fluid balances. If you have diabetes insipidus, you are urinating, you're producing too much hormone, and it's just going, and you're urinating. And because you are, you're thirsty. Polydipsia, polyuria, only 2 P's, okay? These are all of the things that say about it. And what they do is there's both end of the spectrum where you too much, too little, and the treatment is giving them either vasopressin. Sometimes it's what we give the, hold on. It is also a medication that we do for vasopressin and DDAVP. It's things that we use in order to either stop it or to increase what it's doing. So is it too much or is it too little? But just remember, diabetes insipidus is the pituitary. It's all about the vasopressin, which is anti-diuretic hormone. Are they too much, too little? And either way, we're going to give you either too much or too little urine. Parathyroid it's next to the thyroid, but they're not connected and they do different things. All you need to know, it regulates calcium. Calcium is the big thing with parathyroid. And then adrenal has everything to do with cortisol, aldosterone, and sex hormones, okay? Too little of adrenal gland secretion, this child may not have a sexual development normal. They could have a penis and they could have a vagina. They could have testicles and a vagina. You see what I'm saying? It's all different. So they have to assign a sex on them and they'll be given cortisol for life. And then too much is usually what we see in Cushing syndrome. So Cushing syndrome, Addison syndrome, too much, too little. Diabetes mellitus. Diabetes mellitus is all about sugar. And when we talk about diabetes, let's make it very simple for you. Diabetes mellitus, polyphagia, polyuria, polydipsia, the triad of 3, okay? When we see that, what is going on in the body? Well, the body doesn't know what to do with the blood sugar. You're eating sugar, it's going in, the pancreas is not secreting insulin, which digests it. So what happens? Sugar's everywhere. But the body says, I'm hungry. I need to eat. So what does it do? It goes to fats and proteins. And what is the byproduct of that? ketones. Therefore, diabetic ketone acidosis is when somehow the insulin's not working, blood sugar's high, you check the urine and you see proteins because the body's smart. It's going to eat. It's going to eat proteins, it's going to eat fats. So basically, that's what all I said right there. All right. What happens to that child who does not treat their blood sugars seriously and they don't have their diet the way they should? I've known even nurses and techs in the hospital, type 1 diabetes, eat a cake and they say, oh, don't worry, I'll crank up the insulin. Why is that not good? Well, when I tell these, especially adolescents, that come in DKA, and I saw them earlier in the year for the same, to girls, I will say, do you realize that what you're doing could burn your eyes and you could become blind? You've got beautiful eyes. Why do you want to do that? What do I tell a boy? There's neuropathy, and that thing down there, it's not going to work anymore. And do you want that? And I want you to know that I did make a difference. In one of the techs I worked with, a boy, he heard what I said and he turned his life around and started really taking care of himself. I said, you're lucky so far, but be careful. Blindness, of course, circulation, that's why amputations, just like it would be adults, kidney disease, and of course, those neuropathies. Children, if they are young and have diabetes, they are type 1 and they're always type 1. Adolescents, usually that are overweight, are usually type 2. They can correct it. Type 1's never corrected. Gestational is you're pregnant, and sometimes they need to watch diabetes. They'll be getting insulin, even type 2s, these pregnant, because oral glycemics don't work on pregnancy. Usually, later on in life, they can become diabetic too, okay? And then some defects in chromosomes, 6, 7, 12, 20, are some of those that can affect diabetes. Now, what makes you diabetic? What are the numbers you're going to look for? Well, adults is 100 and less glucose, right? Well, they give kids a little more, 126. But that is after not eating for 8 hours. Sometimes you'll see the type 1, it's autoimmune. And then type 2 is just means they're resistant. Insulin is not working. And this, as again, it's because this child is not gaining weight, is overweight, not moving, likes to play video games all day, right? So as I said, it's the triad: polydipsia, polyuria, polyphagia. I've seen them very young, 2 and 3 years old. What we see is all of a sudden they've lost 5 pounds in a week and the parents notice it. Or they start seeing them urinating and hungry, and then thirsty. They're like, what's going on here? Then it gets to the point where they're lethargic, they're weak. And that's, when it's gone on for a little bit longer than a couple of weeks. Their skin gets dry, and then sometimes there's yeast infections in adolescent girls. And why? I don't know, but it happens. Maybe it's part of the dryness. What do we see in diabetes type 1? Well, you're going to see that glucose in the urine. When, remember, this is before we treat them. So you're going to see glucose in the urine, and you're going to see protein in the urine, because what are they eating? Proteins and fat, right? And we know that glucose can be, and I've seen up to over 1,000, and we can correct and we can change it, but we need to give fluids, we need to give insulin, and then these children need to be really counseled on how to take care of themselves. We do random blood sugars, that's what we do, those deck sticks, whatever time, before meals and at bedtime. And children should be taught how to do this. Fasting glucose in the morning when they wake up. Glucose tolerance test. A lot of that's done in pregnancy, right? And then the hemoglobin A1C. We know that adults, 6 is borderline, 6.5, you say you have diabetes type 2, right? But look at children. It is that 9 is what we're looking for. Again, they need more sugar to survive. They're younger, they're more active, they're growing, right? So that is the difference between adults and children. So if we have a 7 on a child, we're happy. That is good. Diabetic ketoacidosis, as I started out with earlier, is high blood sugars, and the body doesn't have insulin for whatever reason. And the body said, I'm hungry, and it eats the fats and proteins. So the sugars in the blood are really high, up to 1,000, like I've seen. And you'll see 4 plus ketones in the urine. And this is, they can go into a coma with this. When we do a blood gas on them, their pH and that 1,000 blood sugar was 6.9. That is almost death in many languages. 7.45 is your normal. 3 to 5, I'll accept that. 6.9 is extremely acidotic. Their breath blows off sugar. They have so much sugar in them, you can smell it. And do you know what it smells like? It smells like you put a peach in a Tupperware container and put it in the refrigerator and forgot it for a month or two. Took it out and we're like, oh, maybe I shouldn't open it. And you do. And this sickening sweet smell hits you. That is that acetone fruity breath that you feel. Okay. And again, they're not getting sugar. Their level of consciousness is not going to be where they should be. So again, you need to teach these children what to do, how to do it. And again, if it's financial, making sure that you get, as nurses, you can get the financial people, the social workers, whatever they need to give them what they need. And some things that you don't think about. What about that person, the Jewish person who doesn't eat pork? There's pork-based insulin. You wouldn't prescribe that to them. And it's something you don't think about. There's beef and there's pork. Again, diet, giving insulin, monitoring blood sugars, and making sure that they're active. We know that's good. And with any diabetic, we need to let them know the insulin. When is it going to peak? When should I watch out for hypoglycemia, right? Those blood glucoses, diet, getting dietitians in there. And then, of course, we know the neuropathies and circulation, skin care, foot care, infections. We know stress affects everything, right? And of course, checking their urines. And if they're traveling, they're in sports, they really need to know blood sugars before sports, keep a snack with them, keep well hydrated, and in travel, make sure that they've got their medicines and that they're following up the way that they should. One of the things that we need to describe is just because it says it's dietetic, look at the label. Some of them are high in carbohydrates. So again, reading labels and making sure they know how to do food choices. Now, fiber. Increasing fiber in the diet can decrease blood sugar levels. I had this one friend's mother of mine who said, drinking cucumber, eating cucumber water was helped me. But that's not proven yet. It's the fiber. The fiber does a lot of good stuff for you. Where do you give insulin? Well, it's sub-Q. It's a tiny little amount, right? In an insulin needle, and it should be given legs, their arms, the abdomen, and of course that rotation, of course. And then we do have sometimes today, even with those pens, because they're very expensive, you want to give 2 types of insulin at the same time. And what they say, clear before cloudy, when you pull it up into a syringe. This pump has been revolutionary. And I've actually seen a little kid this young. Usually they say not till like 7 or 8, they should be older than that to give it. but I've seen younger kids give it, and they could take and put that little needle into the skin, secure it to stay there for a week. So they've only gotten one stick. And they can look at their pump and they can bolus it and everything. It is an amazing thing that keeps these children that they're not just tied down to shot, shot, shot all the time. And you have some kids who don't want to do that. So this is a great thing. Plus, it's continuous. There's not insulin, no insulin, insulin, no insulin, blood sugar up, blood sugar down, right? Because all that rebound stuff can also cause damage. Insulin shock is just too much insulin, which means you have no blood sugar. And we know that's all because you haven't eaten, that you didn't eat as much, or maybe you went out and exercised, didn't take something before, and your blood sugar was low. There's all different things that can cause insulin shock. We know children are always growing, right? They grow quick. Some of them, they're 5 pounds in 6 months, 3 inches. Kids are all different in the way they grow. So it's very hard to regulate them. So they need to really understand hypoglycemia. Okay. So if they start looking hungry, weak, pale, they need, and that sweating is one of those telltale signs. And they're not going to be as alert many of the times. They need to take something. Sugar of some form. Honey is a great one. It's concentrated, right? Sugar, orange juice, I've seen skim milk, something. And of course, if they are unconscious, it's the glucagon. And remember, turn them to the side because they will vomit. They always vomit after glucagon. Now, there's different things that happen with blood sugars. So, Samoji phenomenon, hypoglycemia during the night and high glucose is in the morning. So you go to bed at night, it goes low, but when you wake up, there's like this rebound thing. Sometimes what they say is they need less, not more insulin. So it's opposite of what you think. Dawn phenomenon is when early morning blood glucoses are low, and it has nothing to do with the night stuff. So both of them, when your blood sugars are up and down with these phenomenons, it's just, of course, regulating it the best we can. Type 2 diabetes is becoming more and more because of children and loving their game pads and loving their phones, and they're not up and moving the way they used to. I mean, I came home, there was nothing on TV, there was no cartoons. I had to get up and go out and ride a bike and go somewhere and do something, right? Today, does that happen as much? Well, sometimes it's the neighborhood, but many times it's, oh, I'd just rather play a game, right? Play a game with my buddies and them, and they're not moving. And what happens? They are snacking, they're gaining weight because they're not moving. And of course, it depends on what their diet is. So with diabetes type 2, usually it's hypoglycemic medicines, but remember, it needs to be with a diet also. So that was endocrine. All right, we have a short, I think it's 35, cahoots. Who wants to win today? Kimberly wants to win. Amy, do you want to win today? Look at that. All right, Catherine. I think the person who wants to win, Teresa. You're very competitive. I get to know you all after a while. We should be done right about quarter after. And then you can be off with your weekend. And I can go start celebrating my birthday tomorrow. If I told you how old I was, you would say, no, you're not. I'm an old lady. Young at heart, guys. Don't worry. I'm young at heart. Let's just get going. Week 8, chapters 29 to 32. Lots of stuff. The nurse caring for a child with nephrotic syndrome was alert to which classic symptoms of this disorder? Remember, this has nothing to do with kidney failure. What does the kidney say? That's how you'll remember that. It's a syndrome of the kidneys, nephrotic, that says, hey, protein, I don't like you. And what you'll see is because there's not protein in the vasculature, it pushes out into the tissue. So you're swollen, especially the face and the eyes. That's the big first one. And of course, you're tired. And of course, that protein, the kidneys say, I don't want you. Protein's going to be in the urine. 4 plus. It's going to be frothy. A multi. Genital urinary surgery is especially stressful for preschool children. What factors lend to this stress? Preschoolers ages 3 to about 6. So children at this time, you look at preschooler and it's that castration. It's they feel you're going to cut it off down there. Okay. Also, remember, they're curious. They're starting to touch themselves. And anything that happens to a kid at this point, they feel like it was a punishment to them. I hit my sister yesterday. That's why I have a fever and I'm sick today. Or the treatment's a punishment. That is so into children at this age. Another multi. What special considerations are related to long-term prednisone therapy in preschoolers? What do we know about prednisone? I'll tell you one thing, you're going to be checking blood sugars, right? Because prednisone can increase blood sugars. You're going to be immunosuppressed, your risk for infection. You're immunosuppressed, you're going to delay immunizations. And would it be an alteration in nutrition? No. Yeah, they might be more hungry, but it's not like something to the bad. And it has nothing to do with sex organs. That's cortisol. To prevent urinary tract infection, which is the best beverage for the nurse to recommend to keep urine acidic. Now, this is something I've learned. I've always been taught cranberry juice, right? Haven't you all heard that? Yeah. Well, thank goodness it's this because my grandson, this is all he wants to drink. And that's apple juice, believe it or not. Apple juice prevents urinary tract infections. Something that I learned doing this research for you. When weighing the diaper and subtracting the weight of a dry diaper, the nurse records 30 grams and documents what? So the diaper was 60, right? That question doesn't make sense. So it is 30. Now, what you do is you weigh the wet diaper and then you know the weight of the dry diaper. Type 1, size 1 diapers are 30 grams. So if it comes out there's 60 grams on the scale, you subtract and the answer is 30. Okay? A multi. Strategies to prevent a reoccurrence of a urinary tract infection in a child. Front to back, lots of fluids. Cotton underwear really help. And then, of course, not frequent, but minimal, if none, bubble baths. When do you correct the hypospadias of a newborn? Remember, hypospadias is when the opening is on the bottom of the penis instead on the end. And epispadias is the one on top. They're both done, treated the same way. And you do it really before they're potty trained, right about 18 months. Very good. Foreskin is retracted and very tight on the shaft of the penis. You're unable to return it over the head of the penis. What do? So you pulled it down, you cleaned it. It doesn't come up. It's stuck down over the shaft. What do? You're going to notify the charge nurse. It's actually an emergency. And what they actually do is they put cool on it to try to shrink it to get it back. Okay? It is an emergency. You're cutting off the blood supply to the penis. Which urinary diversion procedure is the least damaging to the body image of an adolescent? So remember, sometimes the bladder doesn't work right. We've got to put it somewhere else because the structure don't work. Adolescents, body image, body image, body image, right? Now, three of these are up on the abdomen of the adolescent. They don't want it. An ilia conduit attaches it to the rectum into the intestines so that they're not going to have it shown on the outside so they can appear normal even on with a bathing suit, okay? That's why. Which physical assessment will the nurse omit when caring for a 2-year-old diagnosed with a Wilms tumor? What do you know about that kidney tumor? What did I say? Your priority. Yeah, we're going to do radiation, chemo, surgery, get it out. They do okay with it. But before they're going to surgery, you're not going to be touching that belly. Remember, that touching of it, that tumor is fragile. It breaks pieces off and metastasis goes into the peritoneum. We don't want that, okay? Leave it alone. Don't touch it. Be careful changing diapers if there are diapers. What is the probable cause of acute glomerulonephritis? Acute glomerulonephritis and rheumatic fever, strep throat. Strep throat. How do we treat it? Treat the strep, long-term antibiotics. A multi. What will the nurse caring for a newborn with exstrophy of the bladder include in the care? Remember, exstrophy of the bladder is the bladder born on the outside of the abdomen. What did I tell you need to do with that? So we need them on their back. They can't go on their bellies. Protect the skin. You're not going to cover the exposed bladder with a shield. It's more like a wet, sterile dressing. Doesn't need they're not going on their back. They don't need it protected that way. They need it there softly open so it can just urinate normally. Child's brought into the ER with burns on the face and chest. What is the nurse's first priority? What did I tell you about burns that are up here? I mean, the answer is you're going to do all of those things, but priority, are they breathing? Did they burn in their mouth? I'd open their mouth and I would look inside. Look at their nose hairs, if they have nose hairs, right? Another multi. What should the nurse stress teach to the mother of a child with impetigo? That was my little Christian. So they're little cuts and bites, like the mosquito bites that my grandson was scratching. Make sure you treat them, that you clean them, put an antibiotic ointment or something on them. Keep the nails short at this point. Remember, this is an infection. This is strep staph, and they're like bullious juicy, and they ooze. Okay, and it was on the back of my grandson's knee where he bent, so it was quite painful for him. Another multi. Which factor activates the herpes simplex virus type 1? And it's a little bit of everything, isn't it? Well, fever, sun for sure. Stress is always, it causes so many things. And then that hormonal thing, menses, yes, it's part of it too. Football players are taking oral grisulfulin for tinea pedis. What should the school nurse caution them to avoid? Grisulfulin is an antifungal. And if they're taking oral pills, antifungal, this is one thing you need to make sure they understand. If you drink when you're taking an antifungal, you will be like you are on antabuse for alcoholics. You will vomit and vomit and vomit and vomit uncontrollably. Antifungals, no alcohol, because you will, and it will be horrible vomiting. What is the correct nursing response to a mother who asks, how can I get rid of the baby's cradle cap? Remember, it's that crusty thing on the head. And, we want to put bows in there wants our babies to look cute, right? So if we put oil on at night, shampoo them in the morning, a soft brush in a couple of days, it might be a week or more, but we will get that off and then that head will look nice and pretty the way we want it to. Child experience intense itching in the axilla and between the fingers and is worse at night. What's that? Which one of these? And the key words here are worse at night. It's scabies. You get it between the fingers and at night. Those are things that will clue you to that. Eczema is anywhere, not necessarily between the fingers, and it's worse all the time, not just night. An adolescent presents with a butterfly rash. What diagnosis does the nurse expect? What is a butterfly rash? And that's lupus. Very good. A multi. Which food sources are high in soluble fiber? Remember, in constipation, one of the things that we need to do is give a good fiber, right? To help them stool more frequently. Of course, increase fluids. but we would give beans and raw fruit, not cooked. Cooked is already the fibers out of them. So raw fruits and beans are your high in soluble fibers. A hemoglobin A1C test can evaluate average glucose levels over a period of blank to blank months. Remember, children is elevated, it's higher than adults. We can go up to a 9 and be okay on a child. I mean, that's getting the borderline, but it's not bad. Usually they're about 7, 7.5, but it's somewhere between 3 to 4 months. And what it tells you is how are they going up and down. And they could say, all right, your average glucose is this. And we know then your blood sugar has been elevated. What occurs as a result of an inadequate secretion of insulin? So if you don't have insulin, what happens? So you go to fat and protein, and you're going to have ketonuria. Another thing is you're going to have elevated blood sugars. A child receives a combination of regular and NPH insulin at 8 a.m. And the 8:45, the breakfast trays have not come yet. What does this mean? Do you have to do anything with this? So the key word in this is regular insulin. Regular insulin really takes effect quickly, right? And you're covering a blood sugar. And if you don't have food yet, they need a snack waiting for that breakfast tray, or they can go hypoglycemic. Very good, guys. A child with diabetes is brought into the ER. He's flushed and drowsy. His skin is dry. The child is experiencing what? I think the key word here is drowsy. They get very tired. They can't hold their head. They're pale. Many of them are wheeled in a wheelchair, believe it or not. And this is when they're in a diabetic ketoacidosis. This is their blood sugars are high, and they're starting to eat proteins and fats, and they're just dehydrated, and they just are miserable, altered consciousness. Absolutely. A child with type 1 diabetes mellitus has hyperglycemia, diaphoresis, and headaches in the morning. What is this called? Remember, low at night, high in the morning. Which one? And if we do see this, because we're monitoring those blood sugars well, then we can do some adjustments. And that's emoji phenomenon. Very good. Not bad at all on that question. What is the function of an insulin pump? So remember, insulin IV, the only one that can be given IV is regular insulin. It's the only one that can break down and be used. Just so that you know it. So it is a constant, slow infusion of insulin. As I said, blood sugars maintain pretty close to a normal instead of up and down with just injections of it. A multi. What signs and symptoms will alert the parents of a possibility of ketoacidosis? 'Acidosis? So when you talk ketoacidosis, it's diabetic ketoacidosis. And yeah, they're nauseous and they're going to smell like those rotten peaches, that fruity breath. Very good. Another multi. I like them today, don't I? Why our children are more prone to insulin reactions? I give you a lot of the select alls because I want you to think. I want you to try to pick it out. Most of the answers are more obvious to you, so you guys been doing good. So we know that insulin reactions, they're more unstable, they're growing, they're active more, they tend to have outbursts of, activities, they're eating, the way they eat, all of those things are all part of problems with diabetes and insulin in children. What type of precautions are necessary with varicella? Varicella is chickenpox. So it's airborne. Remember N95 mask? Remember that. It's airborne. One of the things with varicella, if we see that sort of rash and we're suspecting in any child, number one, put a mask on yourself. Mask on the child and get them to a room where it's that airflow. Airborne is very important. It spread very easily, even if you have the vaccine. What vaccine would be contraindicated for an 18-month-old allergic to eggs? And it's the influenza. Very good, guys. A rash was present on the trunk, extremities, face, and cheeks were bright red. Type of rash is this? Slapped cheeks, bright red. That's the big clue here. Didn't go through it within the PowerPoint, but it's one of those things that you will see. And it's called fifth disease. It's also called slap face, big bright red, and then there's rashes everywhere. Fifth disease. That's a question Hesses and NCLEX loves, believe it or not. Fifth disease, slap face. A child is in the prodromal stage of varicella. What does that mean? They have the disease. They've been exposed. They have the disease, but you don't see the rash yet. It's that week that you were exposed a week ago. That is prodromal. When should a hepatitis B vaccine be given to an infant born to a hepatitis B positive mother? I mean, we know the hepatitis B is given at the hospital before they go home. That is what we know. But a hepatitis B positive mother, does it make a difference? And it does. They need to be given it pretty soon, within 12 hours after birth, to prevent that child from getting it. Which classification of medication would make a child more susceptible to an opportunistic infection? Mentioned it a couple times. I think you're getting the point here. You look at susceptible to an infection, immunosuppressed. What makes you immunosuppressed? That's how I would look at that question. And it is corticosteroids. Very good. And last question. Of course, it's a multi. What sources are examples of acquired immunity? It's either you've had the vaccine or you had the disease. That's acquired. Immunoglobulin, gamma-globin, we use those to fight things like IVIG, like Kawasaki, right? That's not what we're doing. When you have immunity, you've acquired it. You've had the vaccine or you have the disease. Number 3, KW. Number 2, Katie. Good job, Katie. Number 1, Garshell. Look at you, girl. Whoop, whoop. Whitney and a fall. Okay. Let me get you out of here. So that's the end of week 8. That's the beginning of my Hesty setup for you at next week. But we are at week 8. Next week is your exam. Remember, try to come a little bit early so we can set you up. Again, on Sunday, 2 o'clock, I'm going to be doing some review on calculations. Anybody who wants to come is welcome, and I'll make that mention. And there's 2 worksheets I'll send with it. I'm going to put it on your announcement today with the recordings, okay? Thank you, everybody. Have a nice Labor Day weekend. I hope you get a little time to catch up or nap a little bit, whatever you can do, okay? Bye, guys.
Happy birthday.
Thank you so much.